Good morning and good evening, everyone. Welcome to the Humans in Space Virtual Pitch Day. My name is Betty Won, an investment manager from Borean, also spearheading the Humans in Space initiative. It is my great pleasure to be your moderator for this wonderful event. The Humans in Space Virtual Pitch Day. My name is Betty Won, an investment manager from Borean, also spearheading the Humans in Space initiative. It is my great pleasure to be your moderator for this one. Sorry about that. I think there was a technical error with YouTube streaming, but going back, yeah. Again, it is my pleasure to invite you to the Humans in Space Virtual Pitch Day. So the Virtual Pitch Day is a two-day pitch program. And for day one today, we are going to hear from startups and researchers that are creating advancements in space healthcare treatments. Once again, I'd like to congratulate all the first round winners of the 2024 Humans in Space Challenge. And we cannot wait to hear your ideas today. But before that, I wanted to thank everyone here on behalf of Borean for joining us. All right, to briefly share with you how today's program would flow, I'm just going to briefly go through the agenda for today. So starting with a brief introduction of the Humans in Space program, we will be introducing the esteemed evaluators for today's pitch. We will then quickly move on to the pitch of the equity investment applicants. We'll also have a short break in between, followed by the presentations from the orbital launch funding applicants, or those teams that are planning to send their experiments to space. As you may already know, the Humans in Space provides two different types of funding. One, equity investment for startups, and two, the orbital launch funding to both startups and researchers who are planning to send their experiments in space. And just to show you or share with you a bit more about the Humans in Space Challenge, as a lot of you guys may already know, the Humans in Space Challenge is a global space healthcare challenge that calls for startups and researchers addressing critical health problems in space and on Earth. So it provides a platform for startups and researchers who are either addressing healthcare problems faced by astronauts or developing breakthrough healthcare solutions by leveraging the space environment to come together and share their ideas. So, ran in the format of a challenge, the program provides a platform for interaction with esteemed leaders within the space healthcare field as evaluators or mentors. We also provide curated accelerator program for the final winners and a network of investors and collaborators. So on the screen, you'll see some of the highlight pictures from last year's final pitch held at Ascend. And in that area, it was really fulfilling to see how the finalists interact also with our partners and judges and form new collaborations. And we really look forward to our final pitch at Ascend at IAC this year as well. So another exciting factor about the Humans in Space initiative is the award part, of course. So the final winners are awarded with either $50,000 of equity investment or up to $250,000 of orbital launch funding to send their experiments in space. And in doing so, they are supported with other in-kind benefits, such as access to exclusive HIS networking events, Amazon credits, alumni connection, and international promotions. So through today's virtual pitch day, we are going to determine the second round winners that will be presenting live at IAC this year. And to help us determine these winners, we have invited 8 evaluators to join us today. They're indeed leaders of space healthcare from both research and commercialization sector. And it is my pleasure to introduce you the evaluators for day one. So we have Stephanie Chablon, Vice President of Strategy and Business Development of Aurelia Institute. We have Dr. Lucy Lowe, Chief Scientist for Microgravity Research from Axiom Space. Dr. Arun Sharma, Assistant Professor of Biomedical Sciences at Cedars-Sinai. Followed by Dr. Solange Massa, CEO of EcoAtoms, and Dr. Einar Sawyer, Director of UC Space Health. Dr. Jancy McPhee, Associate Chief Scientist of NASA HRP. Last but not least, Kelly Geddes Ogborn, Vice President of Space Commerce Institute from Space Foundation. So these amazing panel of judges, as well as the Humans in Space evaluating team that is not on the screen right now, will be evaluating your pitches today. All right, I hope everyone is ready. Again, just a reminder for the presenters, you have 5 minutes to pitch your ideas, and then we're going to move on to the 3-minute Q&A session with the judges. Judges, if you have questions that you want to ask, please use the raise hand feature on Zoom, and I will moderate you into the question during the Q&A session. Right. So without further ado, we'll begin the virtual pitch day 1. So for the first part, we're going to invite applicants or first round winners from the equity investment sector. And the first team that will be presenting today is ExoBiosphere. So ExoBiosphere is a startup based in Luxembourg that leverages the space environment to accelerate drug development. Ladies and gentlemen, Kyle Acherno, the co-founder and CEO of ExoBiosphere. Let us all welcome him with a virtual round of applause.
Thanks, Betty. Hello, everyone. I'd like to first thank the Human in Space team for organizing this pitch, and of course the jury for down selecting us. We're honored to be the first company to present in what I'm sure is going to be a really excellent day. So as was mentioned, I'm the CEO of ExoBiosphere, and in one sentence I can say that ExoBiosphere leverages the orbital high throughput screening to accelerate drug development and enhance drug success rates. We're trying to solve a really big problem in the healthcare industry. The fact that it costs up to $2 billion and takes over 10 years to develop just one drug. And even with all of this money and time, there's still a 90% failure rate. One of the solutions that we think to this problem is to use high throughput drug screening, which is often used on Earth, but we want to do it in space. So what you see here is the MVP called OATS, and it is a 1 mid-deck locker, which is able to fit in International Space Station or commercial space stations. It can host up to 6 384 well plates. And what it's able to do is rapidly screen thousands of potential drug candidates. The idea here is that we build on what we've learned over the past 3 decades of research on the International Space Station. It's the fact that in microgravity, cells are accelerated, their biological process. And in addition, when cells are growing in space, they're able to grow rounder, or in essence, we believe that when the testing is going to be done in space, they are more model human cells, and therefore the success rate is going to be much higher, which is going to result in more success and a reduced clinical failure rate. Now, none of this is going to be possible without a fantastic team. My team members are all going to be on the call if you have some questions later. Dr. Olivia Borgig is our our director of engineering. She has already sent things up to space, including biological payloads. She's been with us doing this for over 8 years. Dr. Bruno Santos has been doing translational research for over a decade as well, including doing high throughput screening. And he built one of the high throughput screeners in Luxembourg. And myself, I've been working in the space industry for over 10 years, started lots of companies, raised over $200 million and did an IPO. So we have a lot of expertise and I think some good differentiators, which are going to make us stand out. When we looked at the humans in space entire ecosystem, we thought that we could contribute in a lot of different ways. First, we noticed that there have not been a lot of bio and R&D platforms. You can see there was only one that was done. So we know that we can contribute there. We also saw that there are some excellent research organizations and companies which we thought we could partner with, including Deep Space Biology. We could do some research jointly with Cedars-Sinai and work with some of the platforms like Axiom. Our value proposition stands out because we already have a customer who's interested in sending some payloads to space. So we have customer-driven requirements. We have partners like the Luxembourg Center for Systems Biome. Our project is going to be funded by the Luxembourg Space Agency and technically overseen by the European Space Agency. And although we have competition here, we sort of see these people as more of cooperators because while some of the work overlaps, we do think that there's a lot of work, a lot of opportunities to collaborate. We're going to be working in an enormous market. The pharmaceutical industry itself is over 280 billion. For that, we think our TAM is about 150 billion, with our service adjustable market at about 1.5 billion annually over the next 10 years. We're targeting some of the big companies and also some forward-thinking ones. And as I mentioned, we already have some first customers. So in the last 30 seconds, I just want to let you know where we are. The founders have invested $100,000 of 100,000 euros of our own money to get this started. And we're looking right now for 1 million euros of strategic investment. We're going to follow that up with a first grant from the European Space Agency through the Luxembourg Space Agency of about 1.5 million, which we hope will get us to our MVP. Thank you very much for listening, and we're looking forward to your questions.
All right. Thank you, Kyle, for the wonderful presentation. We're now going to invite the judges to the Q&A session. So let us move on to the Q&A. So judges, if you have any questions, please use the raise hand feature and I will moderate you into the Q&A session. Right. Yes, thank you, Dr. Arun Sharma. Please feel free to share your questions with us.
Yeah, thanks, Kyle, for that great presentation. I just wanted to know a little bit more about the potential types of cells that you'll be utilizing in this approach, whether it's organoids, two-dimensional, different types of stem cells. Have you given some thought into what specific cell types you would want to use for this approach?
Yes, for sure. And Betty, am I able to pass to Bruno for this one, please?
Presentation? Sorry.
Oh, no, Bruno. I think Bruno can respond.
Bruno, yes.
Yeah.
Bruno, please feel free to turn on your camera and mic when you're ready.
Yeah. Thanks for the question. So we are definitely aiming for human-based IPS models and then performing different differentiations. We intend to implement hydrogel-based cultures, making it 3D. And of course, many of our extra services will be dependent on the clients that we get. If clients will want to go into cancer, then we have to develop cultures that are specific for the project in question.
Yes, thank you very much, Bruno, and thank you, Dr. Sharma. Kelly, please feel free to share your questions with us.
Thank you, Betty, and thank you, Kyle, for that presentation. My question is around the commercialization plan. You mentioned that one of your areas is, addressing the pharmaceutical industry, and you talked about the total addressable market that you want to attack. In what timeline do you think that you'll start to have penetration, since the yield of what you're able to manufacture and produce now, since this is a budding field, is still somewhat small? So what does that 3, 5, 7-year timeline look like?
Yeah, thanks, Kelly. So I can answer that briefly. We think it's going to take a couple of years, of course, to get the oats on to station. And then in the first years, we're going to be able to do just 1 or 2 million. What we showed was the MVP. And over time, we're going to be developing like a 2 MDL system, which will be able to host our cell plates and then eventually an entire rack. So we think it will take about 10 years to get to the point where we can make 1.5 billion. And we have mapped that out from a bottoms up and top down approach. I'm happy to share that with you in the future.
Great, thank you.
Right. Thank you very much, Kelly, and thank you, Kyle. Since we have limited time, so I think if there are no questions, we will be ending the Q&A session for the first pitch. Thank you very much.
Thanks, everybody.
Thank you. Thank you, Kyle. It was a really great start for the virtual pitch day. Now moving on to the second presentation. The second presentation is Ambrosia Space Manufacturing Corporation. So Ambrosia Space Manufacturing Corporation is an early stage startup based in the US that enables scaled biomanufacturing in space. So please welcome to the stage Mario Maggio, the CEO and founder of Ambrosia Space Manufacturing Corporation.
Thank you, Betty. And just making sure that I can hear me and I'm ready to go. So thank you guys for having us here today. And it's been an honor to talk to everyone. Now it is time to talk a little bit about Ambrosia Space. We are biomanufacturing that in space to make better drugs today and settle Mars tomorrow. And the reason for that is biologics are a class of drugs produced by cells. These drugs require cold storage today, typically around a refrigeration temperature similar to 2 to 8 degrees Celsius. But 50% of those drugs are mishandled at some point during their storage, which really relates in $35 billion in losses for the pharmaceutical companies every year. And that's on top of the $10 billion they spend on cold chain storage logistics. We're currently focused on the crystallization side here, where this is actually something that has solved the problem in some cases, but that's something that can only happen in space, and current capabilities do not scale. So what Ambrosia Space is doing is we're moving the entire biologic manufacturing process into microgravity. To do that, we're developing biomanufacturing hardware that's enabled to work in microgravity, including bioreactors, centrifuges, and eventually protein A chromatography and other purification systems. We're designing the system for scaling, focused on development at the beginning with a 1 to 5 liter bioreactor and centrifuge, but then stepping up into pilot and manufacturing scale at 50 liters and eventually above 1,000 liters, respectively. Building this long-term factory in orbit allows us to have a similar capital expenditure method to Earth-based factory development, where you have a long period of time to make back the revenue that you spent on capital expenditures. And so we're also designing this to meet CGMP requirements, which is necessary to get FDA-approved drugs. The impact it's going to have is threefold. We're going to be able to have shelf-stable biologics, which will improve drug storage and access. But also, because these crystalline drugs are more soluble, you'll be able to have subcutaneous injection instead of the traditional IV administration of these drugs. Second, this technology is very critical to developing the similar hardware necessary to settle Mars. Biomanufacturing is key for a lot of different aspects of space exploration and settlement, including advanced life support systems, chemical manufacturing, food manufacturing, and waste removal, just to name a couple. And additionally, this will be able to increase R&D capabilities in space, with our first development bioreactor being 10 times larger than anything that's flown to space before. The reason that this is different than a lot of the other companies talking here is we're trying to scale beyond research. We're trying to build larger hardware that will be able to work with the pharmaceutical companies to scale beyond into development and eventually manufacturing. By moving the entire process to space, we're focused on a system beyond just crystallization and focused on a holistic approach. And that will be able to enable an economical production of pharmaceuticals in space. And we're also very specifically focused on monoclonal antibodies because of the unique effects that they have and the benefits that we can provide. CDMOs are an existing business model for biopharma companies where you make revenue based on your dollar per kilogram cost, as well as development costs where you're able to get revenue for, in our case, modifying existing processes to work in microgravity and turn for cash or royalty incentives. And we're targeting on-market drugs, so we have less market risk, less regulatory risk, and our processes are already defined because these customers have already been manufacturing it, lowering both our and the customers' development risks. This market is currently the $20 billion, but that's only 25% of the monoclonal antibodies that are produced. The rest of the 75% are manufactured in-house, but our unique capabilities, where we're manufacturing something that they cannot replicate, creates this market to be more akin to $80 billion in total addressable market, with a growth rate of about 10% per year. The business milestones we're trying to reach here is a steady tech development plan, with our first demo mission happening in Q1 2026, and then we're trying to close our funding round for that in this October, and our first prototypes are currently in development, with future development plans happening as well. The team is myself. I was an aerospace engineer previously at Intuitive Machines in Paragon Space. My incoming co-founder is a VC-backed biotech startup and has 10 years working with mammalian and microbial cell cultures, and have a team of advisors that cover pharmaceutical development, fermentation modeling, and hardware engineering. The reason that we work so well with Humans in Space is we want a permanent human presence in space, and want to work with HIS to do that. And with that, any questions?
Right. Thank you very much, Mario, for the wonderful presentation. We will now move on to the Q&A part. Yes, Dr. Soyan Yi.
Oh, thank you so much for your presentation. I have a little bit of the question about your first presentation thing, and then you talked about the cold chain is a problem and a lot of loss. But even if you are manufacturing drugs on the orbit, and then anyway, we needed to bring it back to the territorial, so we might have a kind of similar chain, cold chain, I guess. And what would be have advantage with manufacturing in a space? And then actually, because your presentation is pretty much short, I think you didn't have a time, but can you talk about your core technology? What is it differentiate from any other space of drug manufacturing and crystallization technology?
So as you said, the crystallization part, that is really the key part that enables shelf stability, which removes a lot of the necessity for cold chain storage after it gets back down to Earth. But for our core technology, we're working on bioreactors and cell separation technology and purification technology that is very similar to what's currently used on Earth. But right now, bioreactors in space and all of the rest of this technology is not something that's been scaled even to what's a development process on Earth, is something that we are not, that we don't have right now in space. So that's what our core technology is.
So if I understand correctly, and you mean the problem, less problem is because it's a manufacturing in space, and after the manufactured and the same cold chain process, right?
No, you get rid of the cold chain process. So you remove that cold chain process.
Thank you very much, Dr. Soyan Yi. We'll first move on to Dr. Einar Sawyer, and then we'll move on to the question from Dr. Solange Massa.
Yeah, hi, thank you very much. I think this is important for many reasons on Earth, and also could be applicable to the issues of medication expiration and damage by radiation on long space flight. So question I have for you, is there any precedent? Is there any demonstration? And I apologize if I somehow missed that in here, but have you, even with an MVP, demonstrated this capability in flight?
That's what that Q1 2026 launch is for. It's going to be the biggest bioreactor flown to space, somewhere between that 1 to 5 liter range, and it's going to be the first of its kind.
So as a precedent, even not at scale, what are you hinging this on? Some research has been done, I'm assuming, that will show that this could be done.
Yeah, there's lots of research showing that bioreactors and cell growth works in space, whether it's, similar people working here in 50 milliliters, 150 milliliter cell growth range. You can show that, but then beyond that, it really hasn't been grown to that larger scale.
I mean, taken all the way through to producing something that would be therapeutic. Has that been done even on a small scale?
No, but the processes are quite similar and not affected by microgravity.
Thank you.
Thank you very much, Dr. Sawyer. Although we're short in time, we'll first we still have the question from Dr. Massa.
Thank you, Mario, for your presentation. I have 3 questions. I'll try to make them fast. One is, first, what you're doing is very important. So my first question is, where's the design? Can we see your bioreactor, right? How are you thinking about this? The second is, how do you catch these crystals versus a flow on a bioreactor, which is a very difficult problem? And the third would be, who's your FDA GMP officer? Thank you.
So I'll start with the last one, is we've opened that conversation, but don't have a specific GMP officer yet. To go backwards in order, the process, the bioreactor, it's in CAD, and I, can't share my screen just yet. But it's, we're going through CFD analysis for that. And then, sorry, I missed the third one.
And the third one is, how do you catch the crystals when you have a process of a bioreactor going on? It's a pretty hard problem.
Yeah, so it's going to be a staged process, just like it would be on Earth, where you need to purify purify the proteins and then crystallize them in a more stable environment than the bioreactor itself.
Thank you.
Awesome.
Thank you very much, Dr. Massa, and thank you, Mario, as well. Before we move on to the third pitch, we want to recognize Dr. Soyani, who has joined us as an evaluator for pitch day 1. Thank you for joining us, and thank you as well to all the evaluators again. I think this is a very productive Q&A session, and can't wait for the third pitch. Okay, so the third presenter is Synapsys Medical Technologies Incorporation. So Synapsys Medical Technologies Incorporation is a healthcare company based in Canada that develops a continuously wearable, non-invasive, accurate hemodynamic monitor and a real-time data analytic platform. So please welcome to the stage Pritam Anbukarusa, the CEO of Synapsys.
Hello, everyone. Can you hear me okay?
Yes, we can hear you clearly.
Hello, everyone. My name is Pritam, and I lead Synapsys Medical Technologies. At Synapsys, we develop hemodynamic monitors for heart health and performance assessment in Earth and beyond. Hemodynamics literally means blood flow analysis, and it's been shown to have a strong correlation with physical health and mental health markers. Specifically, cardiac stability, cognitive function, and psychological stress are all highly important in low Earth and deep space missions. The main issue with current existing hemodynamic monitors is that they are inconvenient, they are stationary to the hospital setting, they are expensive capital equipments, and the gold standard, an invasive arterial line, is a highly invasive procedure. We have developed a non-invasive hemodynamic monitor and edge machine learning platform that enables us to continuously measure critical cardiovascular parameters, process them on device securely, encrypt them, and then share them through interoperable standards such as HL7 FHIR standards. We have a patent pending self-calibration technology, which enables our device to remain accurate under different environmental conditions, including microgravity. We have a proprietary nano sensor and control algorithms that enable us to do this. And our system is actually quite modular, so it's compatible with any thin film sensing array, such as a 2D phase array ultrasound system, for example. Our edge machine learning platform enables us to fast, secure, and reliably process this data and then share them in a secure manner on device. We have started validation studies, and our initial results have been highly promising, and we are continuing to do larger scale validation studies for the rest of the year. So our solution enables a large cost saving due to reduced hospitalizations and improved outcomes for the potential workflows that we are targeting for the Earth-based application. Our system also identifies and helps manage cardiac fitness and deconditioning issues for astronauts in space and for patients on Earth. So our target market is sports medicine and healthcare providers in emergency and recovery room settings. And this is a $4.9 billion market. And our eventual focus is on wearable health, which is a $32 billion market. In space, our focus is on space agencies, astronaut training programs, and space tourism, which is expected to be a $1.6 billion market by 2031. So our business model has 4 main components, which we can monetize independently. So we have the device, which we can charge a flat rate for. And the data from the device can be used to calculate cardiovascular risk models that is covered by CPT and reimbursement codes. And we have a web portal that's used to visualize this data that we charge an annual subscription fee for. We have an AI-enabled end user app, which is a freemium model, and we have a subscription associated with that as well. For the space application, the basic value proposition is the same, but the prices change based on customization and additional testing that is required for mission. So we have carried out a successful paid pilot project with the Canadian Space Agency as a subcontractor, and we are in conversation with them for follow-up projects later this year and early next year. We already have pilot projects planned in multiple geographies, and we have carried out extensive user interviews and studies to find our ideal customer persona, and the cost and workflow focus has also been identified. We have raised nearly $300,000 from various Canadian sources, and multiple strategic partnership discussions are ongoing right now. So we built the prototype, tested the software, and conducted the CSA project in 2023. 2024 was focused primarily on product refinement and validation studies. And in 25, we will be going after the safety certifications and expect a full FDA approval in 2026, which will place us perfectly for a growth in the coming years. We have a strong team with the expertise in materials engineering, computer vision, machine learning, and we have a strong advisory panel in healthcare and business advisors and machine learning to bring our technology to market and to reach our strategic goals. So our solution aligns well with the human in space focus for cardiovascular response and clinical decision support system, enabling astronaut health and safety improvements. And it also has strong dual use potential for both terrestrial and space applications. So with that, I would like to finish my presentation, and I would like to thank Human in Space team and the judges for their time. And I would be happy to answer any questions. Thank you.
Thank you very much, Pritam. Now we'll see if we have any questions from the judges. Yes, Dr. Lucy Liu, please feel free to share your questions with us. Dr. Liu, I think, not sure if anyone can hear yes.
Can you hear me now?
Yes.
Okay,
Thank
apologies for that. So thank you for the very interesting presentation, and this is a very interesting tech. Can you help me understand how this is different to other models that are currently on the market? For example, the Apple Watch that can also monitor a lot of these same kinds of outcomes. Is it something to do with the encryption and the FHIR standards? I just wanted to understand a little bit more about that.
So yeah, we are highly differentiated from Apple Watch because of our ability to measure all of the more critical health relevant cardiovascular parameters. So we can measure continuous blood pressure, cardiac output, stroke volume, which is all highly relevant. So that differentiates us. And we also conform to FHIR standards and interoperability. And we have on-device machine learning, which enables us to do these calculations and make these estimates in a secure and private fashion. So it's self-contained. It does not have to communicate with anything else or to a base station to carry out these estimations. And Apple Watch does not currently do blood pressure, leave alone the more complex and difficult estimations.
Thank you very much, Dr. Liu. Yes, Dr. Sawyer.
Hi, thank you for the interesting presentation and the work you're doing. It would help to have a due diligence grid, a picture that compares you, because there are other competitors, BioButton, that come closer, medical grade devices rather than just the Apple Watch. And it's still unclear to me how you're distinguishing yourself. Some of the things that you measured as metrics may not be applicable in a space environment, may be applicable in a more intensive medical setting. But So it's a little bit unclear to me still how you're distinguishing. If you are doing all closed loop processing and you don't require cloud or internet, that's a big distinguishing feature for the long distance missions where we need untethered medical information in real time or on demand or in time. So is it true that you can do all the processing and give actionable insights without connectivity to cloud or internet?
Yes, yes. So that is our biggest differentiator. So we understand there is a competition in the market. And actually, one of your colleagues, Dr. Sheng Zhu, I was talking to him last week, actually. He visited our lab and we were talking about this exact same problem. So there are definitely other sensors out there that can potentially do this. And we built our system to actually be compatible with them. So we can actually integrate advanced sensors, no problems. But our real secret sauce, our value proposition comes from our ability and our background in machine learning and real-time processing systems to be able to process everything in a self-contained fashion. So we even have experimented with language models that are fully self-contained, which is quite interesting from a long-term mission perspective. So that's our biggest differentiator. It's not necessarily the sensor itself. It's actually a combination of our sensor control system and the machine learning systems that we have for real-time processing.
Okay,
yes.
thank you.
Edge machine learning. That's basically the biggest differentiator that we uniquely can do. And we have a really strong team and background to be able to do it.
Thank you, Dr. Sawyer. We'll have a quick question from Dr. Yi. Dr. Sawyer.
Thank you so much. Yeah, I have a question. Actually, I have a pretty much similar with Dr. Lowe and then Dr. Sawyer. And then I think it would be great if you can show the kind of judge or people's what your differentiation of the technology. I guess sensor might be different and then sensing technology might be different. But as a person who, outside of the industry, it's pretty much it seems similar. And then what makes a differentiation is a kind of question. And maybe later you can do that, not today. And then another one is kind of pricing. I feel a little bit concerned. Of course, in space grade, and then there's a lot of kind of process to certified using in a space. So 15K might not be a big deal. But if you want to sell through the terrestrial market on the ground, even if your technology is totally different from the Apple Watch, it's a more than kind of 10 or 100 times more than another device. It's a quite huge hurdle because even if a medical grade device I'm handling right now is a $15,000, it's harder to getting into the market sometimes if it is a small or kind of decentralized thing. But just kind of wearable device, or you might be think about how you can convince those price for the customer, even if much more functionality than the Apple Watch, we better to concern.
Yeah, that's a pertinent point. So we priced it based on existing medical devices that we would be competing with. We don't really have a direct competition with an Apple Watch or existing wearable devices. That's mostly V2, where we refine and reduce the cost down to a point where we can go after consumer applications. Our primary pricing reason is because we are competing with other medical devices that cost in the $20,000 to even $100,000 range, and it's a durable good, right? It's not a replaceable device, so we can use it for 5 to 10 years time span, and we have a service contract model to allay the price point a little bit more, so you can just pay for it yearly as opposed to pay one big chunk of money at the beginning. So we have interviewed a lot of hospital settings and users of our technology and arrived at the price point that way. But our goal is to bring the price point to lower and lower price points and more competitive with wearable devices eventually. But that's not going to be our focus target market when we get into the market in the next couple of years. But that's a great question. Thank you so much.
Thank you very much, Dr. Yi, and thank you, Pritam. It was a really productive Q&A session. Okay, now quickly moving on to the fourth presentation for today. The fourth presenter is Prometheus Life Technologies. It is a Switzerland startup that aims to revolutionize the production of organoids and drug development. So please welcome to the stage Rafael Röttgen, co-founder and CEO of Prometheus Life Technologies.
Good morning from Singapore. Thank you for having us. We are Prometheus Life Technologies from Zurich, Switzerland, and we enable at-scale commercial production of organoids in microgravity. Our organoids aim at solving some of the big problems in life sciences. As we already heard from Kyle, developing a successful new drug costs on average more than $1.4 billion, substantially because over 80% of drug candidates fail after entering clinical trials. Also, over 100 million animals are estimated to be used in testing every year. Our organoids produced in microgravity. So is the slide moving?
No, you have full control of the slides. Yes.
Okay, so there we go. Our organoids are ethical biological models that can help eliminate inviable drug candidates before they enter expensive clinical trials. When generated from autologous tissue, the organoids can be used in precision, regenerative, and transplantation medicine, helping to improve and save patients' lives. Our organoids are superior to existing organoids. Why? On Earth, you need to use a scaffold or matrix to counteract gravity. Otherwise, the organoids collapse. In microgravity, the cells self-arrange in 3D. Not having such foreign material avoids undesirable cellular reactions, including, of course, rejection issues in regenerative medicine. We observe higher batch uniformity between organoids than on Earth, and such uniformity is solely desired by users who want to have comparable and reproducible results. We also observe better differentiation than on Earth. And on this slide, you can see this better differentiation for two tissue types, cartilage on the left and liver on the right. Ground-produced organoids on top and space microgravity-produced ones on the bottom. Now, to execute on a bold vision like ours, you need a truly interdisciplinary team. You need to understand the biology, and we are a biotech company that uses space to its advantage, but you still do need to understand the space aspects, and you need the business expertise to build and scale a company. We have all of this in this exceptional team. Just a few examples. Quora has flown biology experiments on 9 orbital missions. I'm a space VC, and my fund has invested, for example, in Lambda Vision. Also on the space side, we have advisors like Aaron Kemmer, founder of Maiden Space. Katerina Santos is a senior commercial executive at Novartis. We believe we are the first humans in space company focused on organoids, and we see overlap with many ecosystem members, potential flight partners, potential hardware partners, potential users. We also envision exploring potential joint R&D projects and thought leadership activities. How does our business work? We will charge for the organoids for testing by the plate. For regenerative medicine, it will be by therapy, likely jointly with a clinical partner. Our main costs, raw materials, labor, and space transport. And we think we can already produce organoids at a positive gross margin, and we expect all costs can come down significantly more, and we could explain why. We are also low capital intensity because we will produce on other people's space platforms, like Axiom. Target markets and customers, biological testing, anyone who conducts biological tests, including on preclinical drug candidates, regenerative medicine, hospital groups or other companies involved in providing regenerative medicine care. And the chart on the right gives you just one market size and growth estimate for cell models. You can see that organoids and spheroids are already $1 billion market and estimated to grow at about 20% per year. Competition, the summary on competition is that we believe we are one of the few groups that basically has both the relevant expertise, space expertise, and biotech expertise. And so where are we now on our journey? The academic team, including Quora, successfully produced 472 organoids on two space missions. So the concept is proven. We exclusively licensed this technology and established a company. We built the initial team, raised the first grants of $400,000, including 2 from the European Space Agency, and established our lab. Now we are in the middle of a seed round, have raised $600,000 already of up to $2 million. We're applying for further grants. We're commencing the project of designing our own proprietary commercial scale production hardware jointly with the Swiss Research Institute. We are engaging with the first potential beta testing pilot customers of our organoids, and preliminary market research indicates there's clear customer demand. We target a first flight with the new hardware in 2026, and if that all goes well, we scale. Our biggest challenge is education of the life sciences sector on Earth about space, and we are proactively trying to solve that via thought leadership, and we would love to do this together with humans in space. Thank you so much for having me today. We're really thrilled to be in this ecosystem, and me and Cora are now excited to take your questions. Thank you.
Yes, thank you very much, Raphael. Judges, the floor is open to ask questions. We have also invited Cora from Raphael's team. Yes, Dr. Sharma.
Really great presentation. I had a question about the actual hardware that you're using to facilitate the organoid production. I think maybe this was glossed over a little bit. I mean, the images you show about the symmetry of the organoids is pretty promising, but could you talk more about the hardware that's actually used to enable that?
Maybe I'll start and then Cora can add if she wants. So the two missions that have been flown in the past that proved the concept were extremely simple hardware, basically just vials. There was no microfluidics involved. The point is now when we go to commercial scale hardware, completely redesigning that together with the Swiss Research Institute and with a Swiss government grant. So we're going to include microfluidics. We're also going to include some sensor, and we're going to like stack that in a scale that really makes it commercially very interesting. So we're in the middle of doing this, but we estimate, or what we're trying to do is basically in the same space, in the same volume, have something like at least 5 times the number of organoids, which of course brings our cost down by, simplistically speaking, a factor of 5. But this is basically an ongoing project. We know it works with the really simple vials. We want to make it much better. I hope that answers your question.
Yeah, maybe
Yes,
I
thank
can add to this. So that's true. So we prepared everything beforehand on Earth. So we were ready, and we initiated the differentiation process, and then we brought it up to the ISS, and we really used microgravity as a tool to produce very beautiful, homogeneous, well-developed organoids. So it's really the microgravity that does the job.
Thank you
Thank
very
you.
much. Yes, Dr. Sawyer.
Thank you very much. Exciting presentation. I am again curious about what is novel, what's been licensed. I know you're going to build certain hardware, but these projects are being done also at our institution by my colleague Tammy Chang, specifically for liver, and she's had multiple great demonstrations. So I think it's great. It works. I just am curious about what was novel that you could license out of a lab to do this, because it's being demonstrated. The second question is, have you done this with liver and cartilage? Because I'm an orthopedist, so I'd like to know what's the precedent for this.
Again, I will start, and Cora can probably add much better details than me. So what we license, and this is kept as a trade secret right now, is the biotechnological process to basically produce these organoids, so what media to use, the step-by-step process, and so forth. And we've done 5 different tissue types. Liver, cartilage, neural, adipose, and bone. And Cora, do you want to add anything?
Yeah, that's correct.
And
That's
those
correct.
are real experiments or in flight.
And what we have to say is, to our knowledge, so far nobody is producing on a commercial scale organoids for example, regenerative medicine or for drug testing. And the good thing is that in space, I guess you know that, you do not need any scaffold, any matrices, any gels. So it's really only the pure cells, and we start with mesenchymal stem cells from adult. So you can then in the end take a donor, take the cells from a donor, differentiate them in space and bring it back down to Earth and give it to the donor as a transplant in regenerative medicine. And they are completely pure, they are 100% natural. And what we also saw is that we had 100% yield. So in every sample that we send up, we received organoids very homogeneously, very well differentiated.
All right, thank you very much, Cora. And thank you, Raphael, as well. Yes, thank you and thank you, judges, again for joining us on the Q&A session. Now moving on to the 5th presentation for today. It's going to be the last presentation before our break time. So it's Mobility Z Health. So it's a US startup that provides remote musculoskeletal injury diagnosis and screening. Please welcome to the stage Jashina Patil, CEO of Mobility Z Health.
Hi, everyone. I'm Suchashna Patel, CEO and founder of Mobility Z Health. So, Betty, the slides.
Do you have the control?
Okay. All right. So I started this startup with my own experience with musculoskeletal injuries. So as a researcher, biotech engineer, I did pipetting for almost a decade and did not realize that I had been affected by musculoskeletal injury to primary level. On top of that, working on my space health career, I was selected for the citizen science training. And after wearing the spacesuit, I realized it was limiting my motion and I was unable to do the basic EVA that was the part of the simulated analog missions. This made me wonder that how would an astronaut would be working in space and they won't be able to understand what would be their limiting factors. So there are in-flight musculoskeletal conditions, and there are 219 injuries that have been detected until now. Considering the lunar missions, there have been, in that small span of time when they were on the moon, they were affected by 9 musculoskeletal events, out of which maximum were for hand and wrist, and the rest were for the shoulders. One of the astronauts quoted, "Completing a subsequent EVA would have been very difficult on account of how sore and swollen his hands were." An in-flight musculoskeletal EVA injury restricts the motion and restricts them to work in the environment of space, which are also considered as a top risk for Mars. These conditions can elevate to a level where there could be the need of emergency evacuation, losing permanent functioning of the body parts of the astronaut. So on Earth, what's musculoskeletal injury issue? There are 124 million patients, but there are less number of doctors. After calculating, 2,000 plus patients are affected by delay in care due to per provider in a year. Telehealth cannot diagnose, while in-person diagnosis is possible only for orthopedic injuries. And thus, the delays cause disability. In the remote locations of rural America, 60 million people are having sparse access to musculoskeletal injury care and specialty care, due to which we have built a solution that would not only help millions on Earth, but also hundreds of them currently in space and probably the future generations on Moon and Mars. This is a digital health camera-based AI-enabled applications where remote musculoskeletal injury screening, monitoring, and analysis happens, which leads to collection of patient data, and the data analytics help for clinician decision support and further diagnosis and treatments. This is an AI/ML-enabled technology, patent protected, and it's on a HIPAA-compliant environment currently. This particular tech works in a way where the user, which is astronaut in this case, could have a unique ID and then go through screening 1 and screening 2, which are all camera-based. And this information would lead to more data for the ground control if there is no doctor available in the team, in the crew of astronauts. And then further remote physiological monitoring can happen. The current product stage, we have launched our alpha product in the market, wherein it's currently being piloted internally with our team orthopedic surgeons. Our competitors are working with traditional telehealth modules, while we are differentiated in a factor where we are using virtual triaging, virtual tests, all are camera-based, while our competitors are using traditional camera-based manual capacity traditional analysis. In the global MSK market overview, this particular technology lies in the middle of AI, intersection of AI, digital health, health data, and that summarizes the whole SOM of 363 billion, SAM of 470 billion, and a TAM of 800 billion. This technology further can be used as a kiosk model in every clinic, in every CVS or Walmart that we can see. While in space, this could be used for an embedded technology for the spacecrafts. And we are going to go with the partnerships with, like, if provided an opportunity, with Aurelia, MEDIS, UC Space Health, Howard, and further collaborations with Earth and Beyond, Space Capital, Wavemaker. We are looking forward to have a wholesome global injury data integration platform and further integrating with AI for diagnosis.
Sorry for cutting you off in the middle of the presentation, but due to time limitation and for fairness, we'll have to cut you off there. But I believe we'll have some judges ask questions during the session. So we'll now move on to the Q&A session.
Sure.
Judges, if you have any questions, please use the raise hand function. Yes, Dr. Sawyer.
Hi, thank you very much. These tools are very helpful. I was wondering if you could tell us, I'm in orthopedics and was a physical therapist, just wondering, where is this currently deployed? I saw your due diligence slide. Thank you for that. It's still not clear how this is better than the very crowded space that you're in. But I also just want to point out, make sure you figure out a platform that can be completely closed loop for the longer missions as you're explaining and evolving. But could you tell me how much engagement you already have clinically?
So currently we have launched the product last couple of weeks, and we are currently looking to have internal pilots. We have already secured pilots with employers and some virtual clinics who are already serving thousands of patients.
Right. Thank you very much. Yes.
Great. Awesome. Question for you. I know that it seems like you've tested this on Earth and trained your model, but things behave very differently in microgravity, and the entire human physiology is very different when you're up there. What are the plans to test this model or train a new model on astronauts who are experiencing these problems in microgravity, not necessarily down on Earth?
Right. So that's why we need some opportunity wherein we will be looking to gather this data with some sort of pilots on ISS that would help us to understand what is different from the data that we are collecting on Earth, which is gravity-based. So it's very interesting, and that's why we want to launch it in space, because the gravity works differently on the muscles there and rather than Earth, and that's how we would need to train our AI separately and differently for the space environment. So calibration modules will be different.
Thank you very much. If there are no other questions, we will end the first part of today's virtual pitch day. And to give everyone some room to breathe, we'll have a 3-minute break. So we'll have some, feel free to turn off your camera, drink some water. We'll be showing a brief video on screen that just shares about what humans in space is, but please feel free to take some rest.
Humanity has been a history of endless exploration. Over the decades, we have continued to explore deep in space, far beyond where we are born. People still might ask, what is there in space? Can we live without gravity? Can everyone go to space one day? Can there ever be a second Earth? But while paving the path to find these answers, extraordinary pioneers ask questions in a different way. Can sick people go to space? Can we utilize space environments to enable permanent habitation? Can we enable our children to explore beyond their wildest dreams? These extraordinary questions will transform our everyday existence. It's not for the extraordinary. It's the extraordinary for the ordinary. Now, it's time to reveal the answers. For humans in space.
Hi, everyone. We'll be restarting the virtual pitch day in a few seconds. So we invite all the judges to also join us once again. And so for the second part of today's pitch session, we're going to listen from orbital launch funding applicants. So these are researchers and startups that are planning to test their experiments in space through the Humans in Space funding. And first up, we have Egenta. Egenta is a startup based in the US that develops a device-agnostic autonomous health monitoring and clinical decision support system. So please welcome to the stage Rachna Damiha, founder and CEO of Egenta.
Just unmuting myself. Okay. Hello, everyone. Thanks, Betty. So Egenta has developed a platform for autonomous remote health monitoring, and our technology is exclusively licensed from NASA and has been deployed with leading health providers on Earth, and we're really excited to go back to space with your help. So today, as you know, healthcare in space really relies on real-time communication with ground-based medical providers. And much of the health data that we collect today can only be processed after a flight or before a flight rather than in real time. So Egenta's developed the first real-time autonomous crew health monitoring platform in collaboration with Trish at the Baylor College of Medicine. And what we do is we're able to aggregate and monitor medical data, environmental data, and mission data all together. And we use intelligent agent software, IA software, to automate the analysis, alerting, and communication, process the data to predict health deterioration, and also detect off-nominal conditions. And importantly, all of this runs in real time on the edge, and we've designed it to run on any hardware, in any vehicle, so that we can monitor health across a mission. So this architecture will ultimately be used to develop clinical decision support systems in space so that crews can function more independently of mission control. But even today, it has very big impacts here on Earth. We're working with leading health providers to automate remote monitoring for patients from home and in rural areas. And we're also working with the US Army to develop this platform for disaster response and casualty care in austere conditions. We have an incredible team. I'm just listing the founders here, but I have a background in computer security and developing mission critical systems. And my co-founder, Martin, worked at NASA Ames for over a decade, and he developed the AI technology that we licensed from NASA for our platform. So at NASA, Martin used this technology to develop Occams, which automates the role of an OCA flight officer. And it's currently running today 24/7 in ISS mission control. He also developed the Metabolic Rate Advisor, which is an intelligent agent or astronaut personal assistant that is tested at JSC, as you can see here. And he also developed mobile agents, which automates exploration workflow. And this you can see here was tested at the Mars Desert Research Station. And we're really excited to announce that we've secured a spot to test our technology on an upcoming commercial space flight mission, which we'll announce later in the future. But we really need your help to make this happen. So our plan is to demonstrate the first semi-autonomous platform to monitor astronaut and health in space. And the platform uses intelligent agents, which collect data from consumer devices, from medical grade devices, from environmental devices, including cameras. And all of this is processed by intelligent agents on the edge, where this allows a CMO to view onboard data via a dashboard to receive alerts. And then optionally, we can also keep ground in the loop as communications permit. So one aspect or one of the technologies we'll be testing is to validate contactless sensing. So we've integrated technology that allows an astronaut to capture a short selfie video from his mobile phone. And then we use remote PPG algorithms, which have been validated on Earth, but not yet in space, which use light reflected from the skin to calculate vitals, stress metrics, and even blood markers like hemoglobin. And a successful orbital demonstration will really help us to advance the development of autonomous clinical decision support systems in space, but also help us to improve our algorithms, both for Earth and for space, and to increase our use cases, our platform capabilities, and increase the TRL of our system. Having a little delay in my slides. Here we go. Okay, so this is just a summary of the experiment milestones. Due to time, I won't go in depth for them, but we can discuss this during question and answer. And we have the resources to make this happen. We'll be providing matching funding from our existing customer revenue and from new and existing customers and investors. And we're really excited to collaborate with the HIS community. So because our platform is open and device agnostic, we're interested in discovering new health sensing devices, environmental devices, new machine learning algorithms that can run on the edge, some of the interventions and countermeasures that we've heard about today, and really to power a lot of the research experiments that can benefit from being run on the edge. So I'll stop there since I've run out of time. This is my last slide, but I will just say that we're happy to contribute our vast experience and connections, and we're also looking for investors and advisors and partners to join us on this mission. So thank you.
All right, thank you very much, Rachna. We're now going to invite the judges to ask questions. We'll first start with Dr. Massa. Please feel free to share your question.
Thank you very much for your presentation. And I love the way you wrapped it up, saying, hey, I'm open to investors, collaborators. So that's good.
That's why we're here.
Yeah. Your platform is software only, did I understand correctly? Or you have a hardware component?
So we are primarily software. However, obviously we integrate with hardware devices that we do not manufacture ourselves. So we're completely running on off-the-shelf commercially available hardware, which includes the consumer devices I mentioned to you, like the Apple Watches, Garmin, et cetera, medical devices, environmental monitoring devices. And we also run on COTS edge hardware. So whether it's a laptop, an iPad, or edge servers, the future orbital data centers were designed to be completely device and hardware agnostic.
Perfect. So my second question, sorry, to the rest of the judges. How do you download that data? So do you have an onboard computer that you partner with? What is that logistics?
Yes, as I skipped over that. So we do not need to download that data. It can run on board, on flight. So the data is actually available. The algorithms are available to people who are on board, for example, the CMO officer. We do have protocols in place when communication is available to mission control to download that data in a very efficient way or to replicate the data. So when communications permit, and we understand that that's completely optional and often time delayed.
Thank you.
Thank you very much. Yes, Dr. Yi?
Yeah, I have a kind of similar question, but would love to make sure. So you got all the data from the already existing technology like a Trish and then all kind of wearable devices, kind of like that. So your novel technologies, you combined all those collected data and then analysis with your special and unique AI set and platform and software platform. Is it correct?
That's correct. That's correct.
Okay.
Right. So
Then my next question. Yeah. Then my next question is, and then your kind of unique technology is a kind of light algorithm to embed it on the onboarding computer or device, and then kind of lightweight AI. Then you don't have to connect it with the ground servers and a cloud, and they can do the automatically on a space, right?
Exactly. Right. And mission control does want to be in the loop, but we're designed to be not require that so that data processing can happen on board, analysis can happen on board. And ultimately, we would like to provide real-time guidance and support to create real clinical decision support systems in space, like we're starting to develop on Earth.
Okay, then all of the already existing platforms, and then they just generating a lot of data for you to use, but all they have a different form, even if they open the API and then they are all different. That's the problem of the kind of remote diagnosis. So you guys have a special technology to consolidate all those form into the same format to training or diagnosis your AI, right?
Yes, I should have had you give our pitch. You summarized it very nicely. Yes.
I just want to make sure. Yeah. Okay.
There are a lot of point solutions available today, and we are trying to create a unified platform to really integrate that type of data and apply it to different type of conditions, whether it's radiation monitoring or cardiac monitoring. I see Dr.
Yeah, okay. Yeah. In the future, I would love to help you because we better focus on what you really want to do because it's a little bit kind of blurred. So I just want to make sure. Thank you.
Yeah, you got that. Thank you.
Thank you, Dr. Yi. Dr. Sawyer, we apologize, but due to time constraints, we may have to move on to the next pitch, but really appreciate your interest. Perhaps there's an opportunity in the future.
Yes. Feel free to contact me afterwards if you have questions. That's why we're here, to make contacts, and I appreciate all of the interest. Thank you. Thank you, Betty.
Thank you very much, Rachna, again, for joining us. So the next set of presenters are researchers with breakthrough in-space experiment proposals. So we have 4 teams waiting in line. First, I'm going to invite Charles Chu. First, we have Charles Chu from University of California, San Francisco. He will be presenting a novel approach to infection diagnosis through portable metagenomic next-generation sequencing assay. So let me invite to the stage Charles Chu.
Thank you. I would like to also start by thanking the organizers, thanking Boer Young and the judges for the opportunity to speak with you today. So the title of our project is called Off-Earth Metagenomic Sequencing for Diagnosis of Infections. And this is an application that's jointly provided from UCSF and from Weill Cornell Medicine. Our proposed experiment is actually quite simple. We propose here to demonstrate the use of metagenomic next-generation sequencing, abbreviated MNGS, of astronaut self-collected samples to diagnose infections in space. Our goal is to deploy a portable MNGS-based diagnostic test for infectious diseases aboard the International Space Station and have astronauts collect nasal swab and blood samples, process these samples, and perform real-time sequencing analysis for detection of potential pathogens, including herpes viruses, which have been associated with reactivation in astronauts or under stress conditions. Simultaneously, the samples will be returned to Earth for analysis in a parallel fashion using a gold standard clinically validated MNGS assay that we've developed here. And our vision is that ultimately clinical MNGS test capability will be a key resource for astronauts who are venturing to the Moon, Mars, and other deep space environments. On Earth, we're really unable to diagnose the cause of more than 50% of severe life-threatening illnesses, including pneumonia, sepsis, and infections of the brain and spinal cord. On average, 20 to 30 diagnostic tests for infections are ordered for patients admitted with acute illnesses to the hospital, and delays in diagnosis result in high morbidity and mortality and excess costs. So in space, we're really going to need to have broad-based diagnostic test capability, and that's well demonstrated by the 2 astronauts who are currently stranded aboard the International Space Station, and it really highlights the challenges of returning astronauts to Earth for medical attention. In addition, as space travel becomes more accessible for people worldwide, a larger proportion of astronauts will have chronic medical conditions, including occult infections, and we will encounter community-level transmission of infectious diseases. So our solution here is to equip astronauts with the tools that they need to diagnose infections and ultimately other acute illnesses in space. So the impact of this is that this will be directly applicable to clinical MNGS testing done in low resource and remote settings on Earth, and as well as to address emerging viral pandemics. In addition, this technique can be used to search for life outside of Earth. It can be potentially used for diagnosing non-infectious conditions, and more accurate and rapid diagnosis of infections will inform timely and appropriate treatment. Clinical MGS testing is still novel. There's no FDA-approved test. Our team is well qualified to do this. We've led or co-led multiple astronaut and space biology missions. We were involved, for instance, in the first demonstration of sequencing in space with Kate Rubins. We also have clinical MNGS testing that's been underway, that's been granted breakthrough device designation from the FDA. We have a patented bioinformatics pipeline to do real-time analysis interpretation on the laptop. And we've currently run more than 10,000 samples for diagnosis of infections in hospitalized patients since 2016 using MNGS. We also were awarded the 2021 X Prize Rapid COVID Tested finalists for an at-home assay, showing that we can develop point-of-care assays. And the synergy that we hope to produce with the Humans in Space initiatives are to provide innovations in omics technologies that will ultimately allow this assay to become a tricorder for diagnosis of the disease. It will also address critical gaps in how we diagnose infections during space flight or in distant low resource environments. We'll also develop simplified point-of-care workflows that will be crucial for maintaining the health of astronauts. And we have a very strong track record of doing so. So this is kind of a summary of our experiment. Essentially, many of these steps have already been clinically validated or flight validated, but we're going to bypass the extraction step. We're going to use nanopore sequencing, which is a point-of-care sequencing instrument. We're going to run laptop for real-time analysis. And we'll do parallel experiments in Earth. So the idea is that astronauts will be collecting nasal swabs and blood and processing them aboard the International Space Station. We have significant prior experience. We were involved in the initial missions to do nanopore sequencing with Kate Rubins. You can see a picture of her there. We also have extensive experience with sample biobanking and collection for omics analysis. And we also have an automated pipeline and automated procedures for doing clinical MNGS in point-of-care settings. And then finally, so we do have some pre-equipment preparation challenges. I don't have time to really talk about it, but the main issue is that these protocols have been validated individually, but not in combination. So our goal is to actually pull everything together so that we can conduct clinical metagenomic sequencing in real time. We do have resources to do so. We have funding from the CDC, UCSF clinical labs, and we're actively reaching out to space agencies for support. And I'll finally end by saying that our milestones would be accomplishing these goals, but ultimately the goal would be to be able to commercialize and to work with space agencies and private companies to make these technologies available widely. Thank you.
Thank you very much for that pitch. Now we will invite the judges for the Q&A section. We have Dr. Sawyer. Yes, please feel free to share your question.
Hi, thank you for that great presentation, Dr. Chu. I wanted to ask two questions. One is, do you see other applications? Obviously, infection's critical, but monitoring for changes due to radiation seems like might be potential. And then also changes in the microbiome, which could be potentially hazardous. So I just was curious about those other applications, particularly radiation as a supportive tool in monitoring. And last is, can this be totally untethered ultimately? Can you have complete closed loop processes with this?
Great. Yeah. So those are fantastic questions, Dr. Sawyer. So the answer to your first question, or at least what we're hoping to do, is indeed that we're hoping to expand it beyond infectious diseases. We have some data, for instance, to show that host responses can be diagnostic for other conditions, including autoimmune disease and malignancies. We have some work involving DNA sequencing and looking at methylated DNA as a surrogate for evaluating radiation-associated damage and/or the onset of malignancy or pre-malignant conditions. So our goal is ultimately to expand this beyond infectious diseases. But the point is, we really want to make this a demonstration project to show that we can be able to have equip astronauts with the ability to diagnose acute illnesses or infectious syndromes in space. We haven't gotten to the state where ideally what I think you're asking for is essentially a push button solution where you simply put you put the sample into a box, for instance, and be able to get a result out. We're not there yet. But this is the whole goal of having a tricorder concept. We have been able to automate each of the individual steps, and really it's more of an engineering problem and how we can develop this into a single box that will essentially be a tricorder that will allow us to diagnose disease and in a fully automated fashion.
I was also thinking of, can you do it untethered from Earth so that it could be, even if for multiple steps that required human intervention, could it be done free of communication with Earth?
So that is the goal. In fact, the analysis is going to be entirely on the laptop. And we're going to try and make it as seamless as possible. And so it would only require monitoring, and there wouldn't need to be any communication with the astronaut in the process of doing this. Yes.
Thank you.
Thank you very much, Dr. Sawyer. Yes, Dr. So-Yeon Yi.
Yeah, so actually following up with Dr. Sawyer, and then would love to check it out. So you want to use the current developed ground technology, and then want to making kind of space grade, even if it's not totally minimized or miniaturized or automation, but you want to check it out as a feasibility test in space. Is it correct?
That is absolutely correct. And we have been able to demonstrate in remote Earth environments, including Antarctica, for instance, where we trained a physician actually for 3 days to do nanopore sequencing to diagnose a respiratory infection. She was able to do so. So we want to really be able to have low resource environment capability.
Okay, and then one more kind of following up question. So for doing that, you might have a several target kind of disease and then infection, specific infection, and then maybe after that you want to diversify the kind of vector, right?
No, that's the benefit of metagenomic sequencing. Because nearly all infections are caused by DNA and RNA producing organisms, in principle, a single test could be used to diagnose acute infection from any organism, whether it's a virus, a bacterium, a fungus, or parasite. So we're not using primers or probes here. We're simply sequencing human samples and trying to identify infections broadly.
So, and then, yeah, it means because you have a full DNA sequencing, so depending on the software capability, you can check any kinds of DNA thing. Is it correct?
Correct. That's the whole concept behind clinical metagenomic sequencing. Yeah, it's untargeted. It's an agnostic approach. Yes.
Thank you.
Thank you very much, Dr. Yi. Thank you, Charles Chu, as well. We will now move on to the next presentation. Please welcome to the stage Gaurav Pradhan, researcher from Mayo Clinic. His proposal centers around verifying non-pharmaceutical tool for motion sickness following gravity transition in crewed space exploration. Gaurav, please feel free to take the stage away.
Hello, my name is Gaurav Pradhan, and today I'll be presenting our proposed orbital funding for mitigating motion sickness with galvanic vestibular stimulation. motion sickness is a very common problem in aerospace and in space flight environments. And our rationale for this solution is primarily based on the vestibular input, which plays a major role in the neural basis for motion sickness. The major problem, as we all know, that the alterations in the vestibular sensory processing following G transition leads to head movement sensitivity and motion sickness after coming in the Earth's gravity and after a space flight. So cost that we pay for the motion sickness is most of the astronauts spend too much time recovering from the symptoms. The other one, and it has been shown in the studies that 70% of the crew members have functional performance impairment, which affects their coordination and the balance task. There has been like pharmaceutical approaches where people take a lot of drugs for the anti-nausea medications, which obviously have some side effects such as drowsiness, confusion, and additional dizziness. So to have these problems taken care of, we have a solution that we've been working on for the last 15 years in the form of galvanic vestibular stimulation. So primarily this kind of stimulation is like applying the low electric current behind your mastoid process of behind the ears, which affects the vestibular system. So it has been in like for 150 years, this has been studied that when you send like one place to one ear to other ear, you get like a perception of the motion. But what we are doing here is like actually putting a dual opposing GVS, which is like the bidirectional matching opposite currents delivered simultaneously to each mastoid using electrode pairs independent of any motion stimuli. So what happens is that by providing these opposite polarities, we achieve like a bilateral suppression of vestibular signals, which inhibits the perception of the motion, the movements, and as a result is a sensory paradigm results in the mitigation of motion sickness. So this kind of electric currents definitely have shown in the we have shown in our studies that it suppresses vestibular illusion, which is the primary reason for the motion sickness in high velocity environments or the high motion environments. This kind of technology we have tested in our clinic. It's effective and safe and can be used continuously, and it is especially necessary for launch and landing phases of space flight where there is a maximum motion and the vestibular system, our vestibular system, the inner system, is really having like a lot of information, a lot of motion going on. And since with this kind of technology, we don't provide any sensation of the motion, it is very valuable for the therapeutic intervention for clinical populations having vertigo. Our team has been like existing for 18 years with me and my team have been it's mostly multidisciplinary team with a lot of neurovestibular specialists and aerospace medicine program that we have in the Mayo Clinic. Our prior research have shown that the OGVS has been already worked. We have with the US Department of Defense, we applied this technology in the vehicles where we are given the mismatch, and we have shown that we can mitigate the motion sickness. And just recently, we have completed a study with NASA where we have applied this technology and shown that it can effectively manage the motion sickness. And most importantly, for crew members, it does not affect their functional performance when there is an electricity or the simultaneous currents go on through the OGVS. As far as the humans in space is concerned, we have a lot of synergy in between. We are the collaborators for the neuroscientists who are the past finalists for this program. Our vision for the experiment is to have the OGVS launched into orbital space program where it will be on all the time. We will be doing like a standard timed up go test so that we can see their functional performance test, and we can see the GVS performing throughout the orbital process. To do that, we are planning to do a pre-experiment over here to simulate the same kind of an motion into our rotating chair in our lab, which can provide the same high velocity motion so that we apply the GVS technology. And through this program, we envision to create a prototype so that we can launch it in the space. So this is our milestones quickly, that we do our clinical trials and collect the data so that we can do the miniaturization of the technology to put that technology into the simulated space environment. Thank you.
Thank you, Gaurav, for that wonderful presentation. Now we will invite the judges once again to join us in the Q&A session. Yes, Kelly, please feel free to ask your questions.
Hi, thank you for that presentation. My question is about the current input and if there's a level of customization, because I imagine that motion sickness affects patients differently based on genetic factors, medication, sort of across the board. So can you walk through what that looks like?
Great question. And yes, we definitely have the customization. So what we are doing is we are planning to do like the studies with the customization. So what happens is especially the galvanic vestibular stimulation, the safest range is from like 1 milliamps to 5 milliamps. And that's what we do. So we definitely have like when we do like a baseline testings, we definitely have the customization to have like a kind of a very simple device, very effective device where an individual person can customize it based on the effectiveness of what the range is. 1 milliamp to 5 milliamp, does not look like looks like a small range, but it is very effective in the human physiology, because what happens is that really like 2 milliamps and 3 milliamps becomes like a big transition, and our brain is a smoothing engine. So we are definitely doing the customization during the baseline testing for individualized. And we have in the NASA project, we have done that individualization between 1 to 2.5 milliamp, which is more than sufficient. But yes, that the customization is the primary goal as well.
Great, thank you.
Yes.
Thank you very much. Yes, Dr. Sawyer.
Oh my gosh, that was very interesting. Thank you. Couple of questions. One is there a pre-treatment effect? I also work with ocean rowers, and this is a big problem. And so we do some of our analog work there. Is there a pre-treatment effect? Do you need to taper it when it comes off? And is there any post-treatment effect or a tail? And have you tried it in the actual post-mission ambulatory training, retraining?
So to answer your first question is, can you repeat your first question, please?
Yeah. Is there a pre-treatment effect? If you treat or they have the disturbance, does it give them any protection at all?
We have done in the previous studies, and we have seen that we need to turn on the GVS before the stimulation with the pre-treatment, because by the time you see some symptoms and all those things and we turn on, it's too late. It's too late, because if your nausea is treated, the train has left the station. So this is like a more treatable.
You treat ahead of when there is no disturbance.
There is no disturbance.
Does that give
that doesn't give any additional advantage. You need to turn it on before that. And to your second question, can you repeat your second question, please?
Is there a need to taper, and is there a post-treatment effect? Like, how do you know when you're going to take this off? Because otherwise they just get symptomatic and have to put it back on and behind the curve.
Based on our experiments, we have turned it on. There is no after effect. There is no post-treatment. It's like this kind of technology has an on-off characteristics. So it doesn't has like more post-treatment. Yeah.
Okay. And has it been helpful at all in the vestibular disturbances we see when they're trying to relearn to walk?
Yes, I mean, we have tested them in the rotating chair, and then we have turned it on, and there is no functional impairment that happens because of this technology.
Okay.
Yeah.
Thank you.
Thank you very much, Dr. Sawyer, and thank you very much also, Gaurav, for joining us today. I think it was a very wonderful presentation. Next, we have two researchers presenting today. The next presenter is Niloufar Ali, and from Boise State University. So let us all welcome him to the stage as he shares about his research addressing Parkinson's disease and muscle atrophy. Niloufar, please feel free to take the stage away.
Hello, can you hear me? Okay.
Yes.
All right. Hello, everyone. Deep space travel poses a hidden risk of Parkinsonism. To tackle this, we are introducing a dual approach of prolonged whole body low intensity vibration, or LIV, and NAD+ enhancers. Together, these solutions aim to protect astronauts' health on deep space mission. we are teaming up with trailblazers in PD research and space biology. We are collaborating with Amprion, the innovator behind the first PD biomarker development, and a diverse group of experts, including eminent space biologists, mitochondrial biologists, rodent research, payload mission specialists, and LIV experts, harnessing several decades of experience. Interestingly, we found that PD-related genes, especially alpha-synuclein, remains elevated in astronauts' blood. From the I-4 mission, we have seen that even after 3 days in space, the synuclein levels keep on elevating upon 3 months post recovery. Similarly, OXPHOS and complex 1 levels are also downregulated over the same period of time. All the other missions have also shown that there's a downregulation of complex 1 post spaceflight. Additionally, spaceflight stressors lead to decreased dopamine levels, decreased TH expression in the SN, and also in our simulated microgravity experiments. However, these findings are based on separate studies and only suggest a potential PD-like change and do not pinpoint to what's going on. So our first goal provides direct evidence and new insights into Parkinson's disease mechanism and risk. Using mouse model, we will explore key questions like, do TH neurons die in space or do they recover? If they recover, what will be the mechanism? So we are also investigating the risk of PD genes and the PD risk genes and their levels, and also OXPHOS pathway in the brain after a month post-recovery when they come back from ISS. And our innovative approach includes testing for the potential synucleinopathy using alpha-synuclein seed amplification assay or SAA that is proven to diagnose PD years before the symptom appears. Now, from the studies from both space and Earth reveal that all the space-related studies like aging, mitorodysfunction, neurodegeneration, musculoskeletal loss, even retinal loss, they have NAD plus reduction, and mice lacking NADP synthesizing enzymes are most vulnerable to spaceflight. Leveraging this knowledge, we are proposing NAD plus enhancer, which is nicotinamide mononucleotide, because of its shelf stability, safety, and brain bioavailability. And additionally, we are proposing prolonged LIV, which mimics exercise, combats musculoskeletal loss, and also is in trials for vibration therapy for PD. So it's a multi-mode approach to address multiple space-related ailments. Next slide. So prolonged LIV in mice have shown that reduced cellular senescence, it has reduced cellular senescence, more proliferation, and increase in antioxidant pathway. And our collaborator is sending his LIV device in space in 2025 with MSCs. Shortly for our experiment, we will treat the young adult mice with either LIV or NMN. And half of them will go to the KSC and in the rodent habitat, and other half will go to ISS for 30 days. The mice will keep receiving NMN in the space for 30 days until their return, followed by a 30-day recovery period in Boise State. Pre-launch, we will collect baseline data on motor function, depression, anxiety, behavior. Upon return, we will reevaluate the behavior and measure blood dopamine levels. After 30 days of recovery, we will reassess behavior and dopamine levels and perform SAA assay from CSF. And we'll analyze the postmortem brain for dopaminergic neurons, TH positivity, and Lewy body pathology, as well as we'll perform multiomics, mitochondrial health, and other assays. And Dr. Uzer will help with the musculoskeletal system. And we are also open to sharing the tissue with other HIS cohort and other collaborators. We are looking forward to that. So ultimately, we will address how Parkinson's related changes differ between spaceflight and ground, and whether LIV and NMN and their combination can alleviate space-related PD symptoms and other musculoskeletal, retinal, and other symptoms. So we have secured partners for most of the milestones that we have highlighted here, and the astronaut times is around 130K per hour, excluding medical expenses, and countermeasures like LIV and NAD plus enhancer can optimize both health strategies and cost efficiency. And our research aims to leverage this to provide a better treatment for space-based diseases.
Thank you very much, Niloufar. Due to time constraint, we will now move on to the Q&A session.
Yeah. Thank you.
Thank you. So let me just move through the slides. Yes.
Oh, okay.
Yes, Dr. Lowe.
Hi, yes, thank you. That was a very interesting presentation. How do you propose to apply the LIV to the rodents during spaceflight?
So I may have missed it because the experiment was short. So we are not doing any in-flight LIV treatment. We are doing a pre-flight pre-treatment with LIV and a prolonged treatment, which has been shown in our labs that with a pre-treatment of LIV for 6 weeks before the flight, there is increased level of cell proliferation in the MSCs, and there is more antioxidant pathways going up. So we are leveraging that information, and we are going to pre-treat this mice with the LIV, like the platform whole body vibration system. And then and alongside, we'll have groups with NMN delivery and groups with just LIV, NMN, and LIV plus NMN. So we have like on antioxidant therapy, LIV, and antioxidant plus LIV. So to reduce that space LIV treatment, and we have seen that prolonged LIV does enhance all these antioxidant pathways and reduce it.
Thank you. And is there any literature that shows that astronauts who've flown in space are at a higher risk of Parkinson's disease? Because the data that you presented was from the I4 cohort, which is a very small number and is looking at gene expression, not actual disease progression.
Yes. So currently there is no study, like a big study to prove this. So we are at Gene Lab. We have a PD subgroup where in multiomics, where we are studying all the astronaut related data. And we are trying to see all the brain related data and comparing it with the blood data and comparing it with Michael J. Fox Foundation's PPMI database and PDBP, the genetic databases and all the sorts of comparison. And then we are trying to see that if like what are the specific genes which are there. So there is no behavioral like study so far. So this will be the first one. Although all those things that I showed, that dopamine loss, TH loss, that indicates that there is something going on, because basal ganglia is also very most affected after spaceflight. The volume of basal ganglia remains sustained increase like until up to like 6 months or so after spaceflight from MRI data from astronauts. So isolated experiments, isolated evidence, nobody has done like a consolidated study to prove this yet.
Thank you very much, Nilüfer, and thank you as well, Dr. Lowe. That would be the end for the Q&A session, and I think your research definitely shows how space could be a potential platform to solve diseases, critical diseases on Earth. So thank you for that. So moving on to last but not the least presenter for today, we have Scott Ritter from German Aerospace Center Institute of Aerospace Medicine. His team is developing AI-based SANS monitoring system for astronauts. So let us all invite Scott Ritter. Scott, please feel free to turn on the camera and use your microphone to start the pitch.
Okay, thanks very much for having me, and thanks for the opportunity to pitch retinal diagnostics. So we are the German Aerospace Center, DLR, and our team studies spaceflight-associated neuroocular syndrome, or SANS. And SANS is basically defined as eye and brain changes. Some of these changes include swelling and vision changes, and they pose risk to long-duration human spaceflight. And so we aim to detect and monitor these changes using a lens attached to mobile device cameras to inspect the retina for swelling. And so here's what it looks like. The value that we provide here is real-time AI-supported retinal monitoring and diagnostics for SANS. Our experiment is a tech demo of rapid retinal monitoring for clinical decision support. The vision to be achieved through the experiment is real-time retinal monitoring that can operate independent of ground support and internet connection. Shown in the photo is one of our crew members performing the original tech demo with a mobile device. And going to the next slide here, you can see a little bit what it looks like on the screen. So what we're basically doing is imaging the retina. The problem that we aim to solve is how to help astronauts autonomously monitor the retinas for SANS during long duration missions. And the solution we intend to use here are crew tablets, a lens, assistive AI to monitor SANS, and do that in real time without communication with the ground or internet connection. Clinicians on Earth can also use this equipment as an inexpensive retinal monitoring tool in the field or in remote locations. The impact of our solution in terms of scientific novelty are that it uses existing ISS equipment, it's small, lightweight, it operates in real time and doesn't require internet. This is significant because it increases crew autonomy and aligns with the Artemis goals to provide incrementally Earth-independent solutions for space medical operations. And this could be useful for the Gateway and future long-duration missions. Our team is shown here. We are Dr. Claudia Stern, who is an ophthalmologist and flight surgeon, Dr. Jürgen Drescher, who is with the Technology Transfer and Innovation Office, me, Scott Ritter, a biomedical engineer, and our colleagues Owen and Aidan at the European Astronaut Center. And we also have space agency partnerships, expertise in SANS, mobile diagnostic expertise, tech transfer expertise. We have optics experience and AI experience that makes our team unique for this application. In terms of partnerships and synergies within AHIS, we could have a joint research or technology development with other experiments related to SANS or other startups. One example being a previous AHIS Challenge winner, Lambda Vision, which is manufacturing artificial retinal implants shown in the photo. And the experiment that we propose is a continuation of a previous experiment, which was done during spaceflight, which showed that mobile fundoscopy videos could be collected. And then we use those videos to train AI models and figure out how to improve the performance so that crew could do it faster. So now with this tech demo, we aim to add a new lens, add AI support, and improve the performance so that it can advance the TRL and potentially be used for operational space medicine and support the crew on long duration missions. So in the past, we have some flight heritage. We did an ISS tech demo. We also did parabolic flight experiments and ground analogs before. And the findings were that mobile fundoscopy performed well with minimal training. Crew didn't need ground support and improved their performance over time. And our research experience helps anticipate challenges that may occur. And we have close industrial partnerships that are also useful for this. The anticipated challenges are that we would need to integrate our AI models with the onboard crew tablets, and we would need to integrate our hardware onto the ISS, but we have experience with this before. So although these are challenges, we can overcome them.
Thank you, Scott. We will now have to move on to the Q&A session, given the time limitation.
Sure.
Yes, let us start with Dr. Sawyer.
Thank you. Great presentation. I was just at the DLR, and I think it's impressive that you're working there and getting studies done. It leads me to a question of, have you done some work with subjects in centrifuge? I saw the bed rest studies. I'm just wondering how sensitive the devices to picking up changes? And would it be something you would see in as short a time as a centrifuge experience? Or is it longer? And how far into the bed rest studies did you see changes? Just looking at the sensitivity of this.
We don't use the device directly in the centrifuge, but we use the device to measure eye changes in patients who underwent centrifuge.
And how long did they have to be in the centrifuge for you to see an effect with your device?
Oh, we don't know if there was an effect due to the centrifuge. We basically use the device in a long-term countermeasure comparison study in which some of the cohort were centrifuged and some were not. We weren't specifically looking at that as an outcome. We were mostly just looking at general changes.
Okay.
That's a good question. We could look into that. We haven't.
Yeah, we're
yet.
trying to find out how soon do these effects start happening. And so that's why I was asking. Thank you.
Okay.
Thank you very much, Dr. Sawyer. Yes, Stephanie.
Thank you. Very interesting presentation. I understand that you've tested the actual lens itself and it's gone up to microgravity, which is great. How far along are you in training the actual model? So have you used the model to actually accurately predict whether or not there are changes happening to the retina? And if not, what is the development timeline for that model?
So we've trained the models and tested them in bed rest. So they detect changes in bed rest. We have not done that in spaceflight, and that's the purpose of this proposal.
And do you know what the accuracy of the models have been in that simulation, bed rest?
Preliminarily, well, we haven't published that, and preliminarily it looks fine, but we're constantly improving the models because we're constantly getting new data from bed rest.
Okay, thank you.
Thank you very much. We'll have the last question from Dr. Lowe.
Yes, thank you. I'll be quick. Thank you for joining us if it's so late at night or early in the morning if you're in Germany right now. But just to check I understand, so the hardware for this has been flown previously, but the innovative aspect for this particular application is the AI integration of the software for the analysis. Is that correct?
We updated the lens. So the new aspects are both hardware and software.
Okay, thank you.
So we improved the lens basically, and we added AI to the software. Yeah.
Thank you very much. Yes, so that was the last pitch for the Humans in Space Virtual Pitch Day. And indeed, SANS is one of the most critical problems that we are aiming to solve for prolonged space exploration. And thank you very much for sharing your pitch, Scott. So I'm positive that all the innovations and research ideas seen here today will be transformative in shaping the future of humanity in space, the ultimate goal of the Humans in Space initiative. So I would just like to share with you some important next steps under the Humans in Space Challenge. So the second round winners selected through the virtual pitch day will be having their final pitch at IAC Milan this year. If you're attending IAC, we invite everyone to join us as well on that day. Lastly, I just wanted to thank all the judges, Stephanie, Kelly, Dr. Sharma, Dr. Yee, Dr. Sawyer, Dr. Lowe, Dr. Massa, Dr. McPhee for your invaluable participation. And thank you also to all the first round winners for preparing such an amazing pitches for the event in such a short time. Remember, the day 2 of the Humans in Space Virtual Pitch Day is going live on August 30th, 8 a.m. ET time. So all of you guys are welcome to tune in and watch the process of selecting the second round winners. Right. I know we're a bit over time, and we thank you again, everyone. You all make Humans in Space possible. I guess we'll see you on August 30. Thank you very much.